Hello everyone, welcome to my video channel. Today I am going to cover regarding autonomic dysreflexia AD or autonomic hyperreflexia. I am going to start with an introduction, the etiology of autonomic dysreflexia, the stimulation can be due to, what are the pathophysiology of autonomic dysreflexia, clinical presentation of autonomic dysreflexia, the treatment and prevention of autonomic dysreflexia. As an introduction, autonomic dysreflexia is a fatal emergency unique to spinal injured patient. Autonomic dysreflexia is associated with massive, disordered autonomic, mainly the sympathetic, response to the specific stimulation in patient with spinal cord injury above the T6 to T8 level, region of the sympathetic outflow. Autonomic dysreflexia is generally defined as a syndrome of susceptible spinal cord injured patient that incorporates the sudden exaggerated reflective increase in blood pressure in response to any stimulus originating below the level of neurological injury. Autonomic dysreflexia, also known as autonomic hyperreflexia, hypertensive autonomic crisis, sympathetic hyperreflexia, autonomic spasticity, paroxysmal hypertension, mass reflex, and visceral autonomic stress syndrome. The higher the level of the spinal cord injury and the more complete, the greater the risk to develop autonomic dysreflexia. The chance of occurrence of autonomic dysreflexia, cervical cord and higher thoracic spinal cord injury has 60 to 90% risk of developing autonomic dysreflexia. Thoracic cord injury per se is around 10 to 20% risk. It is unlikely to develop autonomic dysreflexia if the injury is below T10 level. Autonomic dysreflexia is reported in a non-traumatic spinal cord injury cases. The example, radiation, myelopathy, and cisplatin-induced polyneuropathy, a rare case that has been reported. What are the etiology of autonomic dysreflexia? An episode of autonomic dysreflexia is defined as an increase of systolic blood pressure at least 25 mm mercury or more above the baseline. The significant episode usually have blood pressure of at least 150 mm mercury or more than 40 mm mercury above the patient baseline. Patient with a complete spinal cord injury has higher risk, more than 3 times risk to develop autonomic dysreflexia than those with incomplete spinal cord injury, 91% to 27%. This figure is quoted from Del Fabro A.S. et al., Journal of Spinal Cord Medicine 2018. Although the autonomic dysreflexia has been described in the first day or weeks after the original trauma, it generally does not develop until after the period of initial spinal shock injury, whereby the reflexes have recovered. The earliest reported case of autonomic dysreflexia is at 4th day post-injury, usually around 92% within the first year after the injury. The stimuli or stimulus can be from in 85% of cases, The stimulus is from the urological cause. Example, urinary tract infection, distended bladder, a clogged Foley catheter. Another causes include bowel distension, fecal impaction, constipation, pressure ulcer, clot retention whereby patient develop deep vein thrombosis, any medical procedures, surgeries, fracture, dislocation or infection, example, pancreatitis, cholecystitis. Other causes that can stimulate formation of autonomic dysreflexia include menstrual cramps, sexual stimulation, labor and delivery. Pharmacological causes are rare, but there are reported cases of autonomic dysreflexia with a combination therapy with duloxetine and amitriptyline. Spinal cord injuries below the level of T10 rarely result in autonomic dysreflexia because the splenic innervation remains intact and allows for a compensatory parasympathetic dilatation of the splenic vascular network. What are the pathophysiology of autonomic dysreflexia? Cutaneous or visceral stimulation below the level of injury initiate afferent impulse to the intermediolateral gray columns of the spinal cord that elicit abnormal reflex sympathetic nervous activity from T6 to L2. The sympathetic response is exaggerated due to a lack of compensatory descending parasympathetic stimulation and intrinsic post-traumatic hypersensitivity. This leads to diffuse vasoconstriction, typically to the lower two-thirds of the body, and a significant rise of blood pressure despite the maximum parasympathetic vasodilatory efforts above the level of the injury. In an intact autonomic system, this high BP activates the carotid sinus and aortic arch baroreceptors, leading to a parasympathetic response, slowing the heart rate via vagal nerve activity and causing diffuse vasodilatation to correct the original increase in the sympathetic tone. However, in the setting of spinal cord injury, the normal corrective parasympathetic response from the medullary vasomotor center cannot travel below the level of spinal injury and generalized vasoconstriction affecting the splenic, muscular, vascular, and cutaneous arterial circulatory networks still continues, ultimately leading to a systemic hypertension, a very severe and potentially dangerous condition. The compensatory vagal and parasympathetic stimulation leads to bradycardia and vasodilatation, but only above the level of the spinal cord injury. This picture illustrates the autonomic dysreflexia mechanism. First is started off, example a full bladder or stimulation from the bowel. This sends an afferent stimulation. There is a massive sympathetic response. There will be widespread vasoconstriction that leads to hypertension. Baroreceptors in the blood vessels will detect the hypertensive crisis and send signal to the brain via vagus nerve. Later, the heart rate will slow. There will be a descending inhibitory signal sent, but is blocked at the spinal cord injury level, T6 or above. This cycle will continue until stimulus remove, or fatal complications occur. After a long explanation, I would like to simplify the pathophysiology of autonomic dysreflexia. The stimulation is carried by an intact peripheral sensory nerve to the spinal cord. This signal will stimulate sympathetic plexus. This will lead to peripheral vasoconstriction, therefore the blood pressure will increase. Baroreceptors respond to an increase in the blood pressure and send message to the brainstem. The brainstem in turn stimulates the vagus nerve. This will reduce the heart rate and inhibit the sympathetic message via the spinal cord. The inhibitory message cannot reach sympathetic system as the cord is injured, so the blood pressure remains elevated. This simple illustration shows 1. It started off from stimulation below the level of the cord injury, then there would be a sympathetic plexus stimulation. Number 3, there will be a vasoconstriction of the blood vessels that will increase the blood pressure. This increased blood pressure will be detected by the baroreceptors at the heart region, and the signal message will be sent to the brainstem. The brain will send signals to reduce the heart rate, inhibit the sympathetic response, but the problem is the signal unable to cross below the level of the injury. This vicious cycle will continue till the stimulation or stimulus is withdrawn, etc. What are the clinical features or presentation of autonomic dysreflexia? Patient will present with a pounding severe headache, very high blood pressure, bradycardia with cardiac arrhythmias and atrial fibrillation or flutter with a higher risk of myocardial infarction in a patient who has previously has a coronary artery disease. Stuffed nose, nasal obstruction. Patient will have flushing of the body above the level of the cord injury with sweating. Cool, pale skin below the level of injury due to vasoconstriction. Blurring of vision, nausea and vomiting, dizziness, anxiety and feeling of doom will be present. Initial and common presentation is headache. Headache is sudden, severe throbbing and bilateral. It may be frontal, temporal or occipital. This is caused by vasodilatation superior to the level of the injury. When the cerebral vasodilatation combined with high blood pressure, there is a high risk of lethal stroke. Hypertension may be asymptomatic or severe enough to cause a hypertensive crisis, complicated by pulmonary edema, left ventricular dysfunction, retinal detachment, intracranial hemorrhage, seizures or death. Autonomic dysreflexia is potentially fatal but reversed quickly if stimulation is withdrawn. The treatment of autonomic dysreflexia include the immediate first step to sit the patient upright with the legs dangling and remove any tight clothing or constrictive device, which will help in lowering the patient's blood pressure by inducing the pooling of blood in the abdomen and the lower extremity vessels. Remove or treat the stimulus quickly. Sublingual nifedipine to reduce the blood pressure. Alpha or beta adrenergic blockers for acute management of high blood pressure. Prevent further occurrence, and please be aware of the stimulus. Prevention of autonomic dysreflexia include frequent pressure relief in the bed or chair, to prevent formation of sacral sore, etc. Good catheter management, good bowel care, endoscopic procedure or any surgical procedures to be done under general anesthesia or spinal anesthesia. Sympathectomy or sacral neurectomy or sacral rhizotomy or dorsal root ganglionectomy might help the patient. Okay, that's all for today. I hope you have learned something from this video. See you in the next one. Take care and bye.